Greetings, everybody. I'm Patrick Powell here with you again to talk about treatment interventions in terms of sexual addiction. I'm going to open up my screen to you. There we go. So at this point, you should be able to see the background here. So last week, we ended on touching base with the assessment process for sexual addictions. As you may remember from last week, some of the most common assessments for sexual addiction include screeners that tend to be developed by various treatment centers. And of course, there's the Pathos model developed by Patrick Carnes. We're going to carry over and talk just a little bit more about assessment here in just a moment, but in general, this is our itinerary for today. Discussing a bit about the challenge we have with determining treatment, noting some frequently utilized treatments, discussing where you can start, providing a basic assessment protocol, discussing CBT, psychodynamic approaches, task-oriented approaches, psychopharmacology, self-help groups, and group therapy, and how we support partners. So, part of the issue with determining treatment is the majority of the treatments that we've developed are primarily based upon anecdotal information, meaning we often believe that what we're doing is successful because it's worked with one client or another. Again, there's an incredible paucity of research regarding a shared consensus of treatment of sexual addiction. Again, Del Boy noted that back in 2015. We just don't have an agreement about what we're studying, so we simply can't state that what we are doing is effective. Carnes noted that brief interventions typically don't work because we're dealing with a lot of complex factors. If you think back to the models that I talked about the etiology of sexual addiction, or the model that I proposed, the integrated model, there are factors related to one's upbringing, one's coping skills, various psychological processes and factors. That is complicated in terms of treatment. It's not something we're going to treat in 4 or 5 sessions. Also, when you think about it, the treatment approach is going to have to be multifaceted, probably a significant treatment team approach. So it's not something we're going to address really in a short time frame. I did want to make a note of this. Hook noted that the majority of the studies that we do have where people have focused on assessing sex addiction and treating it have been focused on Caucasian middle-aged heterosexual men. So those studies, the ones that we do have, may not be applicable to the larger populace. Well, when we're approaching someone from a clinical perspective, the first place we are going to focus is assessment. Now, last week we focused on specific assessments that are available, but our first task has to really be a very comprehensive assessment, not just one intake form, not just one screener or something like that, but a clinical interview with the client, his or her family, his or her support system. Those individuals may provide you with invaluable information regarding facets to that client's addiction that you are unaware of, facets that would need to be considered in treatment. Also, evaluating your client's motivation is incredibly important. As you've probably seen in your clinical settings, and if not in clinical settings, as you've probably seen in various TV shows like Intervention and things like that, a person's motivation to proceed through treatment is one of the most important factors in terms of treatment being successful. So you need to establish early on how motivated is this individual. Though this is not the course or this is not really the place to have a long discussion about this, some of you may have heard the stage of change model. That model focuses on a person coming in one of several different stages of readiness to actually go through with therapy, ranging all the way from an individual being unmotivated to an individual being motivated, but trying to determine what he or she needs to change in his or her life, to the action stage, and finally to the maintenance stage. So an individual will come in at various levels of change. Motivational interviewing is an excellent technique when you have a client who does not have the motivation to move forward with therapy. For those of you unfamiliar with motivational interviewing, unlike some other methods that are used with individuals with addiction, motivational interviewing is a non-confrontational model. To give that a little more clarity, when we look at some of the other models that we see for addictions, there's a lot of pressure, there's a lot of conflict. There's a lot of people saying, you have an issue with your addiction. An individual saying, no, I don't. And that just leads to a recurring cycle of denial that eventually that client starts to even believe at some point. With motivational interviewing, we're simply pointing out discrepancies in the client's statements and asking him or her to explain them to us. So if a client comes in and says, I don't have an issue with sexual addiction, I'm not going to immediately go, yes, you do. When he or she makes a statement that would indicate that they do have an issue with sex addiction, I'm going to bring out that discrepancy. And typically it's like a scale. On one hand, you're saying you don't have an issue with sexual addiction, and that's not something you're experiencing. And on the other hand, you just told me that you often feel out of control with your sexual behavior. Can you help me understand that? Puts the focus on the client to really think that through. And that, in my experience, that's much more beneficial than me just confronting a client. Motivational interviewing, outside of helping a client recognize that he or she has an issue, can also be helpful in helping a client decide to move forward in treatment. On one hand, you say you don't want to move forward in treatment because you don't want to talk about your issues and it's rather expensive or that sort of thing, and you don't have the time for it. But on the other hand, your partner said they're leaving you if you don't move forward with therapy. So maybe you can help me understand which of those is more important. Again, it puts the focus and the responsibility on your client to help you make those decisions. Just one thing about treatment in general, any number of psychiatric comorbidities, including co-occurring substance abuse, depression, or other arenas should be assessed because that may need to be a part of your treatment plan. You should not assume automatically that if we treat sexual addiction, the depression, the anxiety, the alcoholism, that's going to dissipate. That needs to be factored into your treatment. If you think back to what we talked about 2 weeks ago, you often see substance abuse and process addictions co-occurring because people bounce back from one or another in terms of, this is my immediate salve or coping skill. Well, this made me feel bad, I'm going to try this one. Well, this made me feel bad, I'm going to try this one. So you really have to address the breadth of your client's issues instead of focusing on just one particular avenue. I spoke about several specific assessments the last time we met. Acorn and UK described a specific assessment process that you could use to determine the dimensions of your client's treatment. Again, this is not just to say, do you have an issue with sex addiction or things like that. This method is used specifically at the beginning of a course of therapy to evaluate the dimensions of sex addiction so that you can determine where you need to focus more clearly in terms of treatment. The W stands for withdrawal, and you can ask a client, have you experienced any withdrawal symptoms when you were unable to engage in sexual activities? People will respond, irritability, anxiety, frustration, that sort of thing. That may be a point when people also reveal that they're using other substances as well. A, adverse consequences. Have you experienced any negative or adverse consequences in terms of sexual behavior? People may talk about lost relationships, financial losses, difficulties in terms of their place of work, difficulties in terms of relationships with their children. Some people may speak about psychological trauma from maybe what they've endured with other people. But this gives you a broader area in terms of how impacted your client has been by his or her addiction. S, inability to stop. Have you ever tried to stop, cut back, and minimize? Has that been successful? No. So you've tried, but you've been unsuccessful. And you can ask, how many times you've attempted things like that. That gives you an idea of, one, if your client's ever tried to address this before. And if you're seeing him on a repeat attempt, well, it's obviously important if your client is coming back second or third time trying to address his or her sexual addiction. But what you can also ascertain from that is, why was it not successful before? That can inform you as the clinician on maybe an interpersonal style that you need to adopt because this last counselor maybe didn't work out for this individual. But it can inform you about why therapy was not successful so that you can modify your own course of therapy. Tolerance and intensity. How intense is it? If your client is reaching a level of intensity where he or she is in physical danger or physically harming themselves, that needs to be addressed, and that may involve a self-harm assessment. If your client has reached tolerance, well, when a client reaches tolerance, he or she escalates their behavior to reach that same sexual high. And that may mean multiple partners, or again, putting oneself in dangerous situations or dangerous sexual practices. So that needs to be addressed. Couple of comments just in terms of this model. Carnes noted that there are various levels of sexual addiction, and I've listed those, here on this PowerPoint. But I think that's what we're talking about when we look at tolerance. Are you on a minor level, a level 2 behavior, or a level 3 behavior? So for example, we'll just walk through typical responses. Let's see. When we look at a level 1 behavior, that might be multiple anonymous partners. Level 2, voyeurism or exhibitionism. Level 3, stalking, rape. Behaviors that would lead one, or that would be deemed criminal activities. So again, when we're talking tolerance, and you can use Carnes' model to look at various levels of sexual addiction, what you want to see is your client progressing, and if he or she is progressing, are they at any of those dangerous levels, either to themselves, it may be level 2 or 3, or to others at level 3. Moving on with the WASTE acronym, E is escape. Do you use sexual activity as an escape from negative mood states? Again, what you can determine from this is you can ascertain, does my client have a coping skill deficit? And if so, that may be a focal area for you. T, time spent. Have you found yourself spending a lot of time preparing for or engaging in sexual activity? That gives you an idea of the amount of time per day your client is spending, and that can be used to evidence how impairing the sexual addiction is. Time has a couple of meanings. You have time spent, time wasted. So those are both involved in that acronym. So I think that is an excellent place to assess the dimensions of your client's issues. Once you determine those dimensions, and once you determine I need to address this, 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 or this, you need to determine a specific treatment approach. There's some that are used more than others. CBT is probably the most commonly used, cognitive behavioral therapy. Psychodynamic approaches that focus on how we relate to other people and our own perception of ourselves. 12-step programs are used often, as they are with multiple other forms of addiction. And psychopharmacological treatment that can be used to manage impulse control or any other number of issues is often used. And we're going to look at all 4 of these, actually. Hook, in 2012, performed a meta-analysis of 14 studies focusing on sex addiction and treatment, and felt there was some evidence for all 4 of the above listed methods, along with ACT, acceptance and commitment therapy. Let's talk about CBT for just a moment, though. I'm assuming that anyone watching this video is at least a master's level clinician, or someone that has an idea of the clinical world and has some idea of CBT. CBT tends to be a brief therapy where we're focusing on the relationship between events, a person's belief system, and some outside consequence. Most CBT treatment is fairly straightforward in terms of what you do every week. Every week you're analyzing that relationship between belief, events, and consequences, and you're assigning homework, and you're disputing, if you're looking at the case of Albert Ellis, you're disputing irrational thoughts. And if you're looking at it in the frame of Beck's work, you're looking at cognitive distortions and that sort of thing. And I'm not going to spend much more time talking about, CBT specifically, but I do want to talk about how it's applied in terms of sexual addiction. If you're applying CBT to sexual addiction, what you're looking for are maladaptive thoughts regarding sexuality and coping. And you're also looking at any compulsive behaviors that you recognize and trying to find any thought patterns that really relate to that. So you can, again, change those thought patterns or dispute those irrational beliefs in the work of REBT, or dispute those cognitive distortions in the way of Beck. But you're trying to find behaviors as they relate to a person's thoughts in conjunction with sexual addiction and compulsion. Garcia in 2016 commented that the CBT approach for sexual addiction is similar to the treatment of drug addiction, and it focuses you on a few specific areas: distorted cognitions, maladaptive feelings and behaviors, motivational interviewing, we just spoke about that, but that's a component of it. Psychoeducation, again, CBT is a very educational theory, so educating people about how we develop wayward thinking or cognitive distortions, educating individuals about how to test those thoughts when they have them in the moment. And finally, relapse prevention, what to do when an individual is in recovery. CBT has some evidence behind it. And out of the approaches we're going to talk about, CBT probably has the most evidence behind it. But it is a very streamlined process. Your initial focus with CBT is to diminish addictive behaviors. And when you can find those core beliefs, those beliefs that are central to a person about who they are, how they engage in the world, and their chances of being successful in the world, your goal is to address those as quickly as you can and to minimize shame. Many individuals with sexual addiction are going to be incredibly ashamed of their behavior because they'll have had likely quite a few sexual scenarios where they walked out feeling depressed, upset, unhappy about either what they did to get there or what they did during the act. So reducing shame is an incredibly important part of CBT work. We confront those irrational beliefs when we can. We train people on how to talk to themselves when they feel sexual urges, sexual compulsions. We train people to dispute, for example, I need to do this to be okay. We train people to dispute those beliefs and to come up with more flexible beliefs. Having sex with someone is a potential course of action, but I can also do A, B, C, and D when I'm feeling frightened, upset, or disturbed. Again, you're specifically going to pay attention to when a person feels sexual compulsions. What is the belief or what is the event that is happening? Because you're wanting to clearly lay out, this is an activating event, this is my belief, and this is the feeling. So for example, if a client has a conflict with his or her partner, that's activating event, that client is trying to self-soothe. That client feels a need to feel better, and that client's tool is sex. That client's belief would be, I need to have sex to feel better, to be okay. And then the consequence is that client has sex, feels bad, feels shame. Okay? What we do with CBT is we try to change that belief. So the same event, this person is in a conflict with their partner. An alternate belief, I could have sex, but ultimately that would make me feel unfulfilled in the long run. I could do this instead, and that would require you to teach your client other coping skills. So your client enacts another coping skill. The result, your client does not feel guilty shame about the sexual act that he or she did not complete. So again, CBT is relatively straightforward, but what you're focusing on is that link between external events and sometimes internal events with a client as well. When you're thinking, whatever client's belief system is, and the emotional consequences. You'll focus on impulse control. You'll identify triggers. What trigger situations result in you feeling more sexually compulsive or hypersexual? What negative thinking patterns limit you from trying other methods to self-soothe? Negative thinking patterns may be something along the lines of, I'm a failure and I'll never be able to take care of myself. And again, motivational interviewing techniques can be used when your clients are struggling to find the motivation to move forward. Psychoeducation has a couple of purposes in CBT. Psychoeducation can be used to educate people about the model itself, but psychoeducation has an incredibly beneficial, it's incredibly beneficial when you're looking at educating the client or the family about how sexual addiction develops, common signs of sexual addiction, what recovery actually looks like, and how to prevent relapse. Providing that information and giving people a broader clinical picture can be incredibly helpful whenever we're looking at maybe a family where people are thinking about leaving this individual, or they're not sure what's happening, they're feeling conflicted. Being able to see what the recovery process looks like may help them anticipate, well, these are some roadblocks we're going to face, along this journey, but it is possible to move forward with treatment and enter into recovery and maybe have a relationship that we feel safe and trusted in again. Just a couple of other comments. When we're looking at CBT, there's a lot of self-monitoring through diaries. Anytime an individual has a sexually compulsive thought, he or she is likely to utilize that diary, because what they're trying to do is to, again, be able to see a clear link between events, internal beliefs about themselves or the world or their chances of being successful, and consequences. And keeping a daily journal is the best way to make that happen, the best way to get a full picture of the multitude of events that could impact an individual. Moving on beyond CBT, let's talk about the psychodynamic approach. Kaplan and Kruger, and Kaplan's done quite a bit of work in this field, noted that psychotherapy in conjunction with, either alone or in conjunction with medication, can be very beneficial for helping people minimize their sexual behaviors and the compulsivity, and to decrease shame. For those of you unfamiliar with psychodynamic work, it's largely the fruit of Sigmund Freud, who developed psychoanalysis. When we look at psychodynamic approaches, they tend to look at a couple of things, and there are a multitude of different treatment approaches within the psychodynamic field. But a lot of those look at our view of ourselves and how we relate to other people. And those two pieces are really pretty key in terms of most psychodynamic approaches. Estalon and Moras noted specific personality characteristics that they felt were apparent in their sample of individuals with sex addiction. And many of these would be addressed through psychodynamic approaches. So affective insecurity, intolerance of frustration, a tendency to action and to act out, a belief in an operative and mechanical sexual mode, presence of a second state during the crisis, the compulsivity system, emotional overflow, difficulty with stability in terms of relationships, conjugal relationships, rational anxiety, affective and social isolation, and masked depression. So again, Estalon and Moras would note some specific areas that if you're a psychodynamic individual, these are some of the areas that you would approach in terms of your particular psychodynamic treatment approach. It's worth noting that Carnes in 2008 recommended a task-oriented model, really separated by 4 years. And for some of you that just heard 4 years, your eyebrows may have shot up to think about being in treatment for 4 years. But I think that really reinforces what I was talking about at the beginning. You are not looking at treating someone in a short-term 6, 7, 8-week treatment. If you look at the slide before this, psychodynamic approaches, you would not treat any of these constructs or these intra or interpersonal issues in that short time frame. If you're treating someone for sex addiction, regardless of whether you're using a psychodynamic approach or, well, really a CBT. CBT is not going to be as brief as it usually is. You're looking at a longer approach. Let's look at Carnes' model for a 4 distinct year model. And what Carnes has noted in this, these are the specific tasks that have to occur with patients over this period of time. In year 1, people break their isolation. They break their dependency on sex. They stop the litany of sexual behavior. They survive withdrawal symptoms. Again, the depression, the agitation, the unease. As they experience shame, they directly address that and reduce it. They work through the various emotions that they're feeling with suddenly having a world full of stressors without your go-to coping skill. And they resolve crisis situations, such as when a person may feel suddenly, I can't do this, I'm just done with it. That's year 1. Years 2 and 3, people rebuild relationships. They develop and experience celibacy. They feel self-affirmation instead of external affirmation, the sort of affirmation that used to come from sexual practices. They change their lifestyles to be less sexual focused. They develop a plan for what to do in the case of relapse. An individual is likely to find some level of spirituality. There's a difference in spirituality and religion, and I'll briefly mention that here. When we talk religion, we're talking about a specific organized belief system. When we're talking about spirituality, that typically involves one's personal thoughts on him or herself, his or her relation to nature, maybe to a specific deity, or maybe to the universe and the purpose of life and that sort of thing. But spirituality is relatively big in the counseling field, as I'm sure many of you know. It's important in terms of sex addiction because up until this point, this person's purpose may have been to find sexual partners or to have sex. Spirituality is another way to anchor individuals in a different meaning in life. And finally, in year 4, further developing a healthy sex life, understanding healthy sexual boundaries, developing healthy relationships with family and friends. So I like Carnes' 4-year model. The nice thing about this model is you can practice CBT, you can practice psychodynamic work, you can practice any number of particular interventions or theoretical applications that you want to. Let's move on and talk about psychopharmacological treatment for just a moment. For those of you that did not catch this, my degree is not in the medical field. I'm a counselor. That's my specific field. I'm a counselor educator as well. I'm a teacher. So psychopharmacology is not my primary form of treatment for clients. However, I typically work in treatment teams, and there is an MD or a psychiatrist that can assess if medication is needed. For your clients with sexual addiction, considering the breadth of the issues that they are facing, I highly encourage you to involve an MD or a psychiatrist on your treatment team. They are the individuals that may provide some medications that address some of the comorbid issues that develop, such as depression, anxiety, and some of these medications can also help with the the compulsivity factor in terms of sexual addiction. Again, psychopharmacological interventions are routinely used in the practice of treating sexual addiction to address depression, ADHD, anxiety, and any other number of issues. Some medications can also specifically be used to lower sexual desire for individuals that are experiencing, again, a heightened degree of sexuality. A few authors have really studied SSRIs to see if they impact symptoms associated with hypersexual disorders. For those of you familiar with SSRIs, they're commonly used to treat depression. However, one of the side effects of that medication is a decrease in libido. So for that reason, the authors wanted to see if this would also impact sex drive for individuals with sexual addiction. What they found is that their subjects reported a significant reductions in all behavior associated with, and I've listed HD because they use the term hypersexual disorder. They also noted that conventional sexual interest and associated behaviors, culturally normative concepts of reciprocal affectionate sexual activity were unaffected, meaning that when they utilized this medication with their sample, they felt symptoms associated with heightened sexuality was impacted and diminished. However, conventional sexual activity was not. Later on, Kafka and Wang found very similar results in their studies. Raymond and Grant used an opioid antagonist to treat addictive behaviors. Interesting study results, 15 out of 19 patients had a significant reduction in hypersexual disorder symptoms. And one thing about that study, that when we look at the sample, 16 of those 19 were taking other medications. So there's no way to know for sure that naltrexone, the opioid antagonist that was utilized, is the direct agent that impacted hypersexual disorder symptoms. It may have been these other medications. It may be naltrexone in a combination with other medications. So there's no real way to know, unfortunately. Well, actually, there is a way to know: repeat testing. Moving on, antiandrogens, testosterone blockers. All of these have been used to target hypersexual disorders. These tend to focus on impacting testosterone and androgen, and they're aversive, for lack of a better phrase. They diminish your level of androgen and testosterone. Some opioid antagonists, again, have been used to treat disorders in limiting sex drive. Again, limiting sex drive is typically not our biggest focus in terms of what we're doing. Our focus is appropriate, healthy sexual boundaries and appropriate ideas in terms of sex, not limiting sex drive. But that approach has been used quite often with individuals that are experiencing hypersexual disorder. So let's move on and talk for just a little bit about self-help groups and group therapy. Let's distinguish these two for a moment before we move forward. Self-help groups typically involve going to a group people that have experienced, your issue, and trying to find some form of, trying to find individuals in that group that have also dealt with an issue and have recovered from it. Group therapy is a little different. Sometimes it's the same thing, but sometimes it's a little different. Sometimes with group therapy, you're not there for help with your issue. You're there to help and give comfort to others. But let's move on and talk for just a little bit. Because we do not have a professional standard for individuals that address sex addiction, there are plenty of people that practice and treat sexual disorders, but there are not many people that treat sexual addiction because, again, we don't have a unified vision for what that is in this field. Because of that, we don't have a lot of counselors who are certified in sex addiction or counselors who are certified in sex addiction. So because of that, we see a lot of individuals who are going to different self-help groups as a means of trying to move forward in terms of therapy. In 2005, there were 73 nationally known self-help groups. 8 of those were designed to help people manage compulsive behaviors. I think that's an important number to note. It's a significant number. Nordfist noted that there are multiple self-help groups for sexual addiction, specifically in the form of Sex Addicts Anonymous, Sexaholics Anonymous, Sexual Compulsive Anonymous, and Sex and Love Addicts Anonymous. Sexual addiction is actually a focus in all of these groups. One interesting thing about them, most are 12-step groups, similar to AA, and treatment goals are typically focused on helping an individual stop or control problematic sexual behaviors, and again, learn new ways to cope with sexual impulses or to cope with frustration when it occurs. Self-help groups, and this is a delineation that I should have made at the beginning, my apologies. Self-help groups tend to not involve a therapist. Group therapy involves a therapist directing that process. So going back, when you look at things like AA and things like that, those are self-help groups. There's no therapist there that's providing that direction there. Group therapy, in contrast to that, actually does involve a therapist leading that discussion. When we look at group therapy, Klumps did a study in 2005 and noticed that those participants reported a significant decrease in anxiety and intra-psychic, intrapersonal conflict regarding sexual desire. So it's worth noting there is some effect. Hayden mentioned that group therapy and self-help groups should be considered in combination with other forms of therapy. And I think that's a great recommendation. If you are treating your client with, say, CBT or with person-centered, it's helpful for that client to be with other people who are experiencing the same issue, because one of the wonderful things about group therapy or self-help groups, people can learn from other people who have experienced the exact same issue. That's different than you as an individual who are providing psychoeducation and clinical techniques. That's a very different experience because you're providing, this is a path to follow and this is what we do. Group therapy and self-help groups involve other people saying, yes, but we have an experience that we can add to this to help this make more sense to you, and maybe you can learn from us as well. So anytime you have a client that you're treating, I think group therapy or self-help groups are great adjunctive services, meaning additional service, but they are not the best sole service. Again, because the issues are so multifaceted, a clinician needs to be involved when you're looking at sexual addiction. And again, I think psychopharmacology is at least great to explore with a client, or at least have that client explore with his or her psychiatrist or MD. It's good to have that person on your team, because if your client needs those medications, it's nice to be able to work with that provider and be a solidified treatment team. A couple of more things I want to talk about before we wrap up for the evening. When you're talking about providing treatment to your client, you may also need to provide support to his or her family and to partners. As I mentioned earlier, it's not uncommon for people with sexual addiction to find partners that also have sex addiction. I mentioned some of the specific apps and websites that people utilize to find partners. Well, those same sites attract a lot of individuals with sexual addiction. So it's not uncommon for people to find one another. If you're treating your client, you may need to refer his or her partner for treatment for sex addiction to a different provider. You may also need to provide some level, but even if that's not the case, if you're addressing a client and he or she has sex addiction, you may also be providing some family therapy, or referring this person rather for family therapy, because they're going to have to rebuild trust, closeness. Communication skills will definitely need to be addressed. How they spend time together, that will probably need to be a focus in terms of family, because ideally when your client is in recovery, he or she is not just going through this alone. They have support. Support makes all the difference in the world. Support is what can turn someone that feels like an absolute failure on one day into someone that feels like a failure that day, but they see a path down the road and they find some comfort. So family therapy is incredibly important if you're going to treat an individual for sex addiction. Kaplan and Kruger noted that individuals with sexual addiction, some of their partners may feel shame, defeat, guilt for not being able to meet their partner's sexual needs. So there may need to be a level of referral for treatment in terms of that as well. And again, some individuals are co-addicts, either with substances, sex addiction, or other processes. So those individuals may need to be referred for treatment themselves. Garcia noted 4 specific stages of family therapy in terms of sexual addiction: pre-recovery stage, crisis stage, shock stage, grief stage. In pre-recovery, spouses or partners confront themselves with their fears that something is wrong with their partner, and they begin to investigate. You see a lot of confrontation during this time. People are checking phones, people are checking to see where people have been and that sort of thing. And you see a lot of denial of issue. But this is the confrontation stage. This occurs before recovery. In crisis stage, spouses begin to address the grief that they're perceiving due to the fact that their partner is likely cheated. And they begin to start to conceptualize what it's like to be married to an individual that has a sexual addiction. During the shock stage, people feel numb. They're somewhat optimistic about their partner's recovery, assuming that they're actually involved in the therapeutic process. And in the grief stage, spouses think about their own personal losses, and they reevaluate what the future is going to look like. Again, I think this is a great model for family therapy, specifically for sexual addiction, because some of the components that you see here are definitely grief and loss components. I think if you're going to provide treatment for sexual addiction, the grief and loss component has to be involved, because there is a loss. There's a loss of identity. There's a loss of way of life. For some individuals, there's a loss of relationship. There's a loss of trust, and so on. So I appreciate that this model includes a grief and therapy component. Bird noted that couples and family therapy might be more helpful than group or individual therapy for some individuals, because the core goal of family therapy is to reconnect, establish trust, and establish boundaries. That is essentially what you are trying to do with sexual addiction in terms of the practical components. So for some individuals, focusing specifically on family therapy may be of more benefit. Bird noted that there is an additional achievement to family therapy not seen in individual therapy: modifying family dynamics to foster long-term recovery. That piece has to be included in our treatment, whether we're using it solely or not. If we are working with an individual who's existing in the context of a partnership, a relationship, a marriage, or a family, having that family involved, having that family encouraging this client, having that family being there for the client when he or she has bad days, and vice versa, this client being there for his or her family whenever they have bad days, that needs to be included. So for anyone that's a family therapist out there, again, we have a model or a stage model for group therapy and family therapy. But in terms of what we're doing as a family therapist, there are an incredible number of models out there that you can utilize. That's really all that we're going to talk about today. Again, we've talked about Part of the challenge with designing treatment approaches, we've talked about some factors to consider at the beginning of treatment, a specific assessment process used to determine treatment. We've talked about CBT, psychodynamic approaches, some psychopharmacological approaches, self-help groups and group therapy, and we've also discussed how we support partners or families of individuals. Next week, we're going to touch base upon relapse and how we prevent relapse. I look forward to talking with you all next week. Safe travels, everyone.